Hi, my name is Chris Sutton, and I'm going to be doing an inhalation and induction video presentation for Pediatrice. So first things first is we have a 7-year-old patient, Emery, who's here for recurrent sore throats. So she's here for a tonsillectomy procedure. We're going to do a room setup at this point. We're going to talk about our equipment. Some of the equipment that we have is starting here. We have our Miller 2-blade. We'd also have an option for Mac 2-blade, but this is what we're going to use as our gliding scope. Some of the other equipment that we have lube, we have an oral airway, and for the ET tube, what we used is we're going to be using a size 6, and I based that off of 8 years of age. So 7 years plus 16 divided by 4, that gave me 6. And so I'm also going to do a 5.5 size, as well as a 5 size, and also a size bigger than a 6.5. Also, we have here our apples, atropine, propofol, phenylephrine, lidocaine, ephedrine, sucks, and our induction drugs as well that I'll discuss later. So for our depth, I forgot to mention this as well. For our depth, for my Ray oral that we'll be using, that's the more appropriate term to use, Ray oral, is for the size based off of the ET size. What I got was 5.75, so I'll times that by 3, and that gave me about 15 centimeters. So we'll go about 15 centimeters down. We also have our like I mentioned, our oral airway. We have our ambu bag, suction. We have our tape. We have an LMA. The size of the LMA is about 2.5, and for a max of 14 mils for our LMA. I mentioned our drugs, and now what we're gonna do, I think I mentioned our ambu bag as well for emergency situation. Okay, now we're gonna go into our machine check. We are going to, we're gonna go from we have our pipeline pressure. We're gonna make sure that there's no crossover with that. We also wanna make sure we have our E tanks are halfway full. And then we'll come over here and we'll check our flow meters, our vaporizers. We're gonna do a low pressure check, and also check our leak 25, make sure there's no leaks anywhere there, make sure our vaporizers are full, our volatile agents are full. Also want to make sure that that the caps are locked or are screwed on tight. We're going to turn on our machine, make sure we have power. We're going to do our O2. We're going to calibrate our O2 analyzer, check our CO2 absorbent, and make sure our monitors are good and ready to go. I also forgot, also the equipment that we want to make sure that we have is our ETCO2, our pericardial stethoscope, our blood pressure cuff, pulse oximeter, temperature probe, warm blanket, inline humidifier, and also fluid warmer. After we've checked all that, make sure we have all those things ready to go. We're going to do want to make sure that our ventilator settings are set up. We're also going to do our high pressure test. We're gonna turn our APL valve to 70. We're gonna use the O2 flush to inflate the reservoir bag so that we can have a pressure on our gauge pressure of 30, and that maintains 30 for at least 10 seconds. All right, so going on to our patient evaluation. Like I mentioned, we have Emery. She's 7 years old, 23 kilograms. We went through medical history. No, she's currently not taking any medications. She doesn't have any anesthesia she doesn't have any anesthesia history, and her family doesn't have any anesthesia history problems, especially with malignant hypothermia. No known allergies. Recent cold, runny nose, flu. No. I asked her and her parents what she ate for breakfast. She reported nothing. She also has an ASA of 1 for physical assessment. I checked her mouth, noticed that she has a grade A airway, a grade 1 airway, and I also auscultated with my stethoscope her lungs, and she had bilateral breath sounds. I explained to her and to the family the anesthetic plan just from induction, maintenance, and emergence. And so now going on to mask induction. I'm going to use my pediatric mask. and I'm going to use the CE method. With my first digit, I'm going to place over the bridge of the mouth, or bridge of the nose, and then for my second digit, over the bottom of the mouth, and then my last digits, I'm going to place under the mandible and push up for a good seal. And then for my gas settings, if she's cooperative, I'm going to turn my SIVO up to 2 to 3%. I'm going to turn my nitrous to 7 liters, O2 to 3 liters. However, if she's uncooperative, then I'm going to maintain my nitrous and O2 pressures at the same liters, and I'm actually going to bump my SIVO up to 8% and use the method smother the little bugger, and I'll open my APL valve. And once she's gone from stage 1 to stage 2, I'll notice that she has discontinent gaze, uncontrolled movements, stiff movements, maybe even tachycardia and hypotension. Some complications would be laryngospasms. Once she arrives into stage 3, which is where we want her at, we want to place an IV, vital signs, and get our Ray oral ready to go. And then at this point, I'm gonna turn the nitrous off. I'm gonna go on to my induction drugs. So I'm gonna give fentanyl based off of 1 micrograms per kilogram. I'm gonna draw up 25 micrograms. Decadron based off of 0.0625 milligrams per kilogram. I'm gonna give 1.4 milligrams. That's what I've drawn up. Propofol based off of 2 milligrams per kilogram. I drew up 46 milligrams, and for Zofran, based off of 0.1 milligram per kilogram, I'm gonna drop 2.3 milligrams, and I'm gonna give those medications. I'm gonna check her vital signs. Vital signs will go down a little bit, but we wanna make sure they're within normal range, and they are. I'm gonna go ahead and take the eyes shut, and we've decreased the gases, our SIVO, and now for the induction phase, I'm going to turn off all the gases so that I don't gas everybody. And I'm going to grab my Miller, and I'm also going to put our patient into a sniff position, flexing the head back and putting some pillows under the shoulders so that all the axes align and I can get a good visual of the structures. And so I'm going to go ahead and put my Miller scope in, gently slide the tongue to the left and push down the epiglottis. So the structures that I'm going to be seeing in order are going to be the base of the tongue, the epiglottis. I'm going to be seeing the corniculates, vocal cords, and glottic opening. At this point, so after I've swept with my Miller and the tongue to the left, I'm going to go ahead and get ready, lube my oral ray, thank you. And we're gonna go ahead and intubate. And we're gonna push we're gonna put it in 15 centimeters all the way until it goes through the cords. So at this point, I'm gonna connect it to the breathing circuit, and we are gonna check for chest rising. I'm gonna manually ventilate at 20. I'm going to turn my APL valve to 20 so we don't push air into the stomach. And I'm going to watch for chest rising, ETCO2 waveforms, and then I'm also going to auscultate for breath sounds bilaterally. Once we're at that point, I'm going to secure it and set our SIVO to 3 to 4% and O2 at 2 liters, and then we're going to look for spontaneous breathing. And then we're going to talk about some complications with this, laryngeal spasms. So things that increase the risk is actually during stage 2, recent illnesses, any type of stimulation, signs and symptoms. If there's no air movement, that's considered a complete laryngeal spasm. If you hear some squeaking or stridor, that's considered an incomplete. Treatment for that is high pressure volume or high pressure ventilation. If that doesn't work, then we're going to deepen the sedation, and I can use my propofol at that point. And then if that doesn't work, then we can use a paralytic like succinylcholine. And I would use, based off of 2 milligrams per kilogram of sux, I would drop 46 milligrams. So complications with that, you can have hypoxia, which can then result with laryngeal spasms. It can cause hypoxia, which can then result in bradycardia. If bradycardia occurs, that usually can be as a result of not only just of hypoxia, even though that's the #1 cause, but also of sux. So a technique with that is you want to give atropine before. So based off of the weight, based off of 0.02 milligrams per kilogram, I would drop about 0.45 milligrams, giving no less than 0.1 milligram, and give that and hopefully counteract that. If there is hypoxia, then we're able to, I guess I'll explain this in just a little bit. Also, another complication that can happen is bronchospasm. A risk with that is light anesthesia, uncontrolled asthma, recent illnesses, pretty similar to laryngeal spasm. Treatment with that, if there's air going through, inhaled albuterol or IV epinephrine. Again, complications of hypoxia, once that's resulted, then you can use O2 supplementation. And then during the emergent phase, you have deep extubation or awake extubation. Deep extubation, the benefits of that, decreased coughing, which can lead to decreased bleeding risks, decreased risk of laryngeal spasm, increased amnesia, smoother emergence, complications, aspiration, unprotected airway, apnea. What you want to do is when you take them into the PACU after you've extubated them, you want to put an oral airway in and put them on in a lateral position. For awake extubation benefits, protected airway, quicker emergence, complications, might have laryngeal spasms, and will most likely remember.